shoulder ultrasound. If we look at the shoulder girdle, we divide shoulder joint into two main parts. The first is anterior shoulder, and then is the posterior part of the shoulder. We scan the patient while the patient is sitting on a stool, and it is appropriate if the radiologist or sonologist or sonographer is standing or is sitting on a revolving stool, which is about 6 to 8 inches higher than the stool of the patient. The stool of the patient is fixed so that we can move around the patient. If we look at the anatomy, we have got anterior shoulder in which we can see the clavicle, and we have the clavicle and acromion, which is the acromioclavicular joint here. This is one important thing which we will be looking in sonography of shoulder joint. Then we have the coracoid process. The coracoid ligament is important here. And then we have the supraspinatus and rotator cuff tendons, like biceps long head is here, and the humeral head, then the shaft and neck of the humerus. This is subscapularis, the broader one. If we look at the posterior aspect, we have got the supraspinatus and infraspinatus with the part of teres minor, which is visible. So we divide shoulder tendons into rotator cuff and non-rotator cuff tendons. Usually on ultrasound, we are looking for rotator cuff, which includes the 5 tendons, which are the supraspinatus, infraspinatus, subscapularis, biceps long head, and teres minor. Ideally, the patient is examined while sitting on a low stool with a rotating backless seat, allowing access to the front side and posterior aspect of the shoulder. So as I mentioned earlier, it is better to stand or sit on a higher stool and move around the patient so we can scan the anterior aspect and posterior part of the shoulder. The examiner is seated adjacent and lateral to the affected shoulder. The arm is placed in a neutral position to begin the examination. This is the neutral position. If patient is sitting on a couch, then obviously we have to stand. We will not have option to sit on a higher stool and move around. So in our setups in developing countries, we usually have a couch on which we are scanning patients for abdomen, gynae, obstetrics, and on same stool, on same couch, we can scan the patient for musculoskeletal ultrasound. Yes, we don't have specific clinical setups to scan only musculoskeletal patients. Otherwise, we could have arranged the stools for them. This is at one of my older clinic in about 2005, where we used to scan the patients for shoulder. This is how the patient will be sitting. We need the shoulders to be exposed. It is obvious that if we have to scan the right shoulder, we will ask the patient to expose the other side, the contralateral side also, so that we can compare if we find any pathology. Especially if there is hypertrophy or atrophy, we can compare the thickness of the tendon on the other side. So although the patient can be examined in a supine position, they must be turned to lie prone in order to examine the posterior components of the rotator cuff. And obviously, a sitting position should be used if possible. We can scan the patient while patient is lying supine on the bed, but it will be difficult to scan whole of the shoulder appropriately. We will not be able to stretch, but if patient is not able to sit, then we will have no choice to let him be lying on the bed supine, and then we can ask him to be prone to see the back of the shoulder. Ultrasound examination of the rotator cuff is best performed with a high resolution, high frequency 7.5 to 12 megahertz linear array transducer, or possibly a curved array of similar frequency where appropriate.